Good day. This is Dr. John Bennett broadcasting from Miami Beach for Neurosurgical TV. Today we have an exciting webinar, Robotics, the Future, with Dr. Kazuhiro Hongo. This conference was put together by Hira. Thanks, Hira, and Dr. Kato and Iype Cheiran. We appreciate it. Let's, introduce Hira and she'll take over. Welcome, Hira.
Thank you, John. Thank you so much. Welcome, everyone. Today's symposium is organized on behalf of Fujita Health University by the recommendation of Professor Yoko Kato, who is the president of the Asian Congress of Neurological Surgeons. We would like to introduce Professor Hongo. He is the professor and chairman, Neurosurgery Department, Shinsu University School of Medicine in Japan. He is going to give a talk on introduction of standard smart cyber operating theaters in the Shinsu University Hospital. Professor Hongo, thank you very much for your presence.
Okay, hello. Thank you for the introduction.
Thank you. Please start.
Can I start?
Yes, please.
Okay. Can you see?
No, you need to screen share first.
Can you see?
No, Professor Hongo, you need to screen share with the green option down there.
Screen share, yes.
You'll get another tab in which you have another option.
Here, I just...
Yeah, you first press the green one, and once you have another tab, then the blue one. Yeah.
Okay. Can you see?
Yes.
Can you see?
Yes, that's perfect.
Okay.
Yeah.
Can I start?
Yes, please. Yeah.
Okay, thank you for the introduction. I'm Hongo from Japan. It's a great honor for me to present my talk today. The title is Introduction of Standard Smart Cyber Operating Theater, SCOT for short, in Shinsu University Hospital. Well, nothing to disclose. Well, first, I'd like to show the cartoon here titled Unmanned Operating Theater in Wonder. This is a scene, operating theater, the surgery, heart surgery is being done without any man, a doctor around the patient. Well, this is the cartoon, Japanese cartoon in 50 years ago in children's magazine. The title is Operating Room in the Future. But 50 years now, I think some of the procedure can be done like this already. But here is our SCOT operating theater I'm talking today. There are various devices, instruments, and then the smart cyber operating theater, SCOT is short. What is SCOT? I'd like to introduce. Well, this is the project research supported by the Japan Agency of Medical Research and Development. We call it AMED. For the last 4 years, included with, collaborated with 5 universities and 12 companies, all Japanese companies, including our university, Shinsu University, and Tokyo Women's Medical University and Hiroshima University, and 12 Japanese companies joined. Well, there are various devices in the operating theater, such as microscope, operating table, navigation, various instruments. But these instruments, devices are used independently, actually. But the SCOT, the project we are doing is connecting all these devices in the same timetable. So that means integrated. And the information is displayed simultaneously. So this means IoT, Internet of Things in an operating theater, operating room, or kind of networking of the operating room. And now this, we call it Iype link for surgery, but as you can see here, online is already being used middleware in the industry. So we brought online system as Iype link at the surgical theater. This is the concept. Now there are various information. This is the system a couple years ago in Tokyo Women's Medical School. The operating room is here. There are various information are gathered in that this strategy with various many displays, but not connected each other. And the supervising doctor is seeing this and just commenting with seeing these various monitors. But how about Scott? We call it the standard Scott in Shinsu University Hospital. We are aiming collect all the intra-operative data at the strategy desk via Iype link and modify surgical procedures by suggestion from the strategy desk as needed. So that can improve surgical qualities with this interaction. Now, this is the scene. There are various information, surgical information like operative video, navigation, surgical power device, and electrophysiological monitoring data or preoperative images and also intraoperative images, and also anesthetic information, patient vital signs, and so forth. All these information are collected at the strategy desk. We can share these information in the same timetable, and then feeding back these information to the operating room team, surgeon in operating theater. And now I can show you, here is the actual operating room we're using, started in June last year. MRI is also installed, the navigation system, there's other instrument, and flow cytometry, intraoperative monitoring, various. Right now, almost 20 instruments, devices are connected with Iype link. Iype link, and here we call it Iype link I. Here is the 80-inch 4K display. Various information are connected with middleware called Iype link, and various information are displayed here in the 80-inch display in the same timetable. And then here the point is communication with strategy desk is possible, like you can see the drawing. Then strategy desk supervising doctor at the strategy desk can see the same information. Here is the same display at in office. The supervising doctor can see all the information and give us suggestion regarding the procedure for the surgery ongoing. So that means two-way connection, two-way information communication is possible. So various information displayed in the same time scale via Iype link. So this is the point of our standard type spot. Okay, and here is the operating room. The surgery is being done. And then here is the strategy desk, and we can see supervising doctor can see all the information and giving. Right. And here,
そうしてください。まずこの内側の方をしっかり取った後また検討しましょう。そうするとここもう一回取るのと、あと先生が取られた摘出限界の。
And here is the screen display. There are various information displayed, and operating macro camera and MRI with preoperative MRI displayed, and also intraoperative MRI is also displayed, updated, and the navigation point is being displayed here. This is another display pattern, and any needed information, necessary information can be added to this display depending on the type of surgery. And then the supervising doctor can see this information and call to the surgeon in the operating room. Here, this feedback is possible, and this is real-time communication is possible. But another good point is review mode. We have review mode even during surgery. We can play back. We can see, for example, 5 minutes or 10 minutes, 30 minutes before the procedure, what the procedure is being done, in which point. In, for example, at that point, we have about MEP power activity, and how about the power of coagulation. All these information are shared, displayed. And then back to the real time. So review mode is very helpful to review, see the procedures, even during surgery, or of course after surgery, of post-operative conference. For example, we can see these videos. Now, for the last couple months, we did just 12 surgeries done with this system, and communication with strategy in all cases nicely done with smoothly. So this is just one case I'd like to show. 13-year-old boy having the medulla astrocytoma here, and it's growing. And then we decided to do surgery, but the maybe total resection are possible, just the debug as maximal debug. Post-operative Barenberg syndrome might be acceptable. So here showing the surgical strategy, and we did surgery, and this Scott system here. My young staff is doing craniotomy, and I'm just in display surgical strategy, and I can guide.
こうなってるよね。後藤先生、聞こえる？
はいはい。
これで見える？
見えます先生。
さっきのコンダイルの面。
Nice communication is possible. And here is the procedure I'm doing at the operating room. Intradural procedure. Even young doctors can see this information displaying the strategy disk. And here showing the intraoperative MRI. For this patient, the medulla, so with small incision, I removed the tumor and confirmed the extent of the resection with intraoperative MRI. And I thought I decided to go further with another small incision. So that makes the patient condition very good. without having the swallowing, speech disturbance, deep sensation intact. So intraoperative MRI is quite helpful in this situation. So I just show one case, but so far we had a very nice result. So the operating theater, this is no ideal unmanned operating theater, but we do the surgery even with robotics technology and with multiple eyes, with communication based on having the various information. Surgeon is of course doing surgery mainly, but there are so many information right now. So this supervising doctor can assist or advise with seeing the various information and feeding it back to the surgeon. I think this is a good system. Here in conclusion, so we have developed an integrated operating room, SCOT for short, which consists of networked surgical resources with OpenLink, and successful result of standard SCOT will contribute to the higher quality of surgery. And also this may help to doing the education for the resident or other even young staff to be more skillful and better neurosurgeon. Okay, thank you very much for your kind attention. That's it.
Thank you so much. Thank you. Professor Hongo, you can stop the screen sharings and we can move forward to the question and answers session.
Okay, here.
Yeah, perfect.
Okay, great.
Okay, thank you so much. That was a wonderful presentation. Any questions and comments from the panelists? Anyone? Professor Cheiran, would you have some comments or questions on this?
Hello.
Yes, yes, we can hear you. Yeah.
Hello, hi, Iype.
Yeah, excellent presentation, Professor Hongo. Very good. I mean, it's this is something of a dream. In fact, we are also working on the same lines. I am actually with Professor Kato. I'm trying to collaborate with some companies. In fact, with Sony and Mitaka for some projects. But for us, it's in the beginning phase. I'll when my talk comes, I'll rather talk about first what we are doing right now and what we are planning to do.
Okay, I'd like to see your presentation.
Yes.
Okay.
Hira?
Yes, yes.
When do you want me to start?
Just after this question answer session. In like 5 minutes?
Yes, please.
Okay, all right. Okay. So I have a question for you, Professor Hongo.
Oh, yes.
Yes. Would you like to tell how many institutes, because when I was back there in Japan, I had the chance to visit Professor Seto at the main campus in Fujita, and they're doing a lot of work for stroke rehabilitation using robotics. So how do you differentiate the use of robotics in these aspects, and how many centers in Japan are equipped for neurosurgical procedures for using robotics?
So robotics, there are various meanings, but the setup, as I just present, is right now just 3. My university in Tokyo, Women's Medical School, Medical University, and Hiroshima, 3 of us. But right now we are planning to export the system as the package in not only Japan, but in any other countries. And I think another type of robotics is under investigation at various universities, like Da Vinci system for neurosurgery. A couple of years ago, in my university, we dealt with, but not realized yet. But technically, I think it's possible for neurosurgical field that we can have the manipulator type robotics. The setup I just talked is another type of technological progress, I think.
Thank you. Thank you. In the meanwhile, let me introduce you to the other panelists we have. Dr. Manuel, can you please introduce yourself? Just a quick introduction.
Hello, my name is Manuel. I am from Dominican Republic. Right now, I am in Moscow. I am resident of neurosurgery.
Welcome. He's from Russia. Professor Dr. Sugar Hinojosa, please introduce yourself.
Yes, my name is Sugar. I'm a neurosurgeon from Peru. I has been 3 months with Dr. Tree and back there in Nepal, so it's really nice to meet you, Dr. Congo. Nice presentation.
Thank you.
Thank you. Warlax, Dr. Warlax, can you please introduce yourself? Warlax seems
she probably stepped away.
Yeah. Dr. Kabulo, are you there?
Yes, I'm there.
Yes, please introduce yourself.
Yes, my name is Dr. Kabulo, final year neurosurgery resident at the University of Zimbabwe under Professor Kalangu. I'm originally from the Democratic Republic of Congo.
Welcome. Dr. Warlax, you need to introduce yourself.
Come on, Warlax.
I'm Warlax I am a neurosurgery resident from Thailand.
Okay. And we have another panelist, but I cannot see your name. It's a number. Can you please? Yes, yeah. Please, can you introduce?
I'm Dr. Venkat, a senior consultant neurosurgeon from Bangalore, India.
Welcome, welcome. Okay, so that is from the first talk. We now move to the second talk.
Excuse me, Hira, could I make a comment or question?
Yes, yes, yes.
Yeah, I'm Dr. John Bennett, Neurosurgical TV. You know, doctors, robotics has made, as you know, a lot of progress in obstetric gynecology and urology, and I guess it's relatively new in neurosurgery. And Iype has a friend, Garnet Sutherland, I guess up in Canada, that has done a lot of work in robotics with NASA. And in America, a lot of the work in robotics is funded by the government. Is it the same in Japan? A lot of the research and the progress is made by research done by funded by the government. Same thing in Japan.
Well, not really same. I know that Professor Sutherland in Calgary is doing a very good job. He's collaborated with national Canadian, but in Japan, Japanese government are trying to make robotics in Japan, but not big budget can be allowed.
Right.
So there is a kind of problem. It's a big budget we need to.
Okay.
Yeah.
Thank you.
Yeah.
Okay. Hira, it's all yours.
Okay, so we have Professor Iype Cheiran. He's the director of the Nobel Institute of Neurosciences in Biratnagar, Nepal. He's keen on working on the robotics project, which will change the future of neurosurgery for sure. Professor Cheiran, it's all yours now. You're muted, Professor Cheiran. You're muted.
Yeah. Good evening to everybody from India. Professor Hongo's talk was outstanding, brilliant. So I've been interested in robotics primarily because my good friend of more than 10 years, Dr. Garnet, was doing the neuro arm, and I was amazed by how the neuro arm was performing. So over the last few years, we were working on a few things, and I am going to present our concept of robotics and what we intend to do. Now, imagine when the first car came into being. If that car had tried to mimic a horse, which was the car's immediate predecessor, that car would have been a failure. Imagine, instead of wheels, if that car had tried to mimic the horse's legs, it would have been difficult. The same way, when Wright brothers made the first aircraft, instead of trying to fly the aircraft by Bernoulli's theorem, if they had tried to have a wing-beating aircraft like the the usual birds, then that aircraft would have been a failure. My whole point of saying this is that when you are going into robotic surgery, you cannot mimic the human hand. So the degrees of freedom, the movements, you just cannot mimic the human hand. The technology has to be completely different. I see that most of the robotic researchers, they're trying to imitate the human hand, which I think will not augur well, because the human hand is just too far complex with its sensory and motor system. I mean, now there are good sensory systems, there are good motor systems for the robots, but I mean, getting this both together with a very superior brain to do an unmanned surgery is still very far away. So what we are looking at is for robotic assistance to help us. So I'll tell you. Now let me start by showing you what the best in theaters are. So I'm going to share my screen, and I'm going to show you what we have in the theaters. I mean, obviously, what I saw with Professor the scholar that we don't, but the conventional theater, as far as the conventional theaters go, I'll show you what we have to start first, and then we'll be able to tell you where the robotics is going to help us. Okay, so this is our operating suite. We have an intraoperative 3 Tesla MRI, which can auto-register with our navigation. We have an O-arm. We have a navigable microscope. All three can be integrated. So the O-arm, with the O-arm, we will know the bone removal. For example, a translab approach, or a anterior petrosectomy, or a posterior petrosectomy, we can know from the O-arm. The intraoperative MRI will tell us about the soft tissue, and with this I can we have the Pentiro where you can navigate, and it will come as a picture-in-picture. Now this is the current technology what we have right now, and so you can see the navigation screens there. So we can navigate and inject these images into the Pentiro. So let me show you, for example, if we are doing a translab or a petrosectomy, this is the O-arm image, which can actually be fused into the MRI images. There are softwares to do this, and with these softwares we'll be able to figure out what exactly is the bone removal. Intraoperatively we'll know where the carotid is, or for endoscopic procedures we can navigate the scope. We have the entire Karlstow's IDA system, which can be again integrated to the navigation. So again, the intraop MRI can be integrated, and if we have a problem, we can take a intraop MRI as well. So fiber tracks, everything can be integrated again. Now this is the current scenario. Now where is robotics going to work? Where is robotics going to work? So we decided we have now three massive things. We have a microscope, which is massive. We have an endoscope, and then we have navigation. So we decided, let us get everything into one with a very small equipment. We only want a robotic holder. So what we did is, let us see this instrument, the first prototype. This has been made with the help of University of Alicante. Eduardo and Pablo Gonzalez from Alicante, we made this. This robot is a much bigger robot. So what it can do is, it can position if we give a mark, it can navigate and position. We are combining an S7 navigation along with this robot, so that the scanned images, if we put a mark on these images, the robot can navigate and go to the mark. So it's basically a holding robot which will show exactly as to where the surgeon is intending to look. So if we have a 3D and 4K camera on a small holding arm, this robot and plus 3D glasses, where you could fuse the real images like a Microsoft HoloLens 2. You could fuse the images of the real images with the virtual images. If we could fuse both, then this is a huge operating visualization tool for the surgeon. We are combining microscope, endoscope, navigation into one. There are many algorithms for this where we can combine the real images with the virtual images, and real-time combination, real-time combining is easily possible. This is just the technology that the flights use to land in a fog without any vision. So usually flights operate in VFR, visual range, but sometimes there is no vision at all, the flights can land. This is because they can combine satellite imagery to the radar imaging, and then they can land exactly point to point they can land. That is the same technology that we can use, so that even in an aneurysm bleed, if the vessel is bleeding, since the aneurysm is relatively a skull-based structure and doesn't really move like in a glioma or anything, we could use to clip it, actually seeing it even when it is bleeding. These are what we are looking at. These are things that we are looking at. So another thing that we are looking at is robotic assistance. So for example, to hold a drill, to hold a CUSA, to hold a suction, to hold various instruments like that and move it precisely with sensory input. Now, you must be aware that there's a lot of instruments that bipolars, suction tips, where you can get sensory inputs, how much force that you're putting into the tissue. So we are looking at robotic assistance for these kind of instruments. We're looking at the visualization device, which combines a microscope, endoscope, and a navigation. He presented this to Yas, and he was very happy because he's the first, he introduced for the first time microsurgical operations in a big way. But you know, the microscope has been growing from big to a mammoth to a dinosaur. So right now it's like an elephant. It's like a huge elephant. So it's between you and your patient. So you don't really need it. So this is what, and plus you have another instrument like the endoscope, which can go in. You can combine all this together with the navigation. You don't have to look at the navigation screen separately. You can combine everything together, and you don't have to look at a screen. You can have a glass. So you can, you don't have to keep looking at a screen. You can look wherever you want, and with the glasses you can operate. And the same vision can be for all your assistants, not only you, but everybody is in the theater can have the same vision. So this is what we are working at the moment. We hope to collaborate with companies. We will update you on what is our progress. Thank you very much.
Thank you so much. That's interesting. Professor Hongo, would you like to comment on this, the ideas? You're muted, Professor Hongo. You need to unmute. Yes.
Can you hear me?
Yeah.
Okay. It's a great talk. I
cannot hear you.
Can you hear me?
One second.
Yes.
Okay. Yes. Great. Well, I understand that you you use a microscope and endoscope and navigation, everything in the same setting with using robotics technology. Well, what is the goal of the best indication? What kind of pathology surgery do you think the best indication for using this technology? And it's vascular tumor.
We are thinking of skull base actually.
Skull base
because
tumors.
In skull base, I mean, we are using simultaneously microscope and endoscope. We have the Mitaka arm. And so in skull-based procedures, we are using microscope. We are doing multi-port surgery. But with the robotic holder and with a good camera like the Widetone 3D, we could actually use it like an endoscope and a microscope. Because if we have anything more than 40 megapixel resolution, and we can have a digital zoom as well without much of a pixelation, and we can get good 4K images. So we are looking at very small axis microscopic surgery for skull base. For example, in an anterior petrosectomy, the size of subtemporal craniotomy that you have to do will be very, very less. For example, in the anterior skull base, you could use an endoscope just like a microscope. It will be 3D, and the zoom and everything will be much more different. So we are looking at skull-based pathologies to start with, but once the navigation can also be integrated and intraoperative imaging can be integrated, then we can look at pathologies like glioma where brain shift is not a problem.
Well, thank you. And I'd like to have another question. Can I have?
Yes, please.
You have a good system to visualize the operating field. And how about the surgeon's hands manipulation? How do you think about its manipulating a system integrated also?
I did not get your question, Professor Hongo.
Well, you have a good visualization, the microscope, endoscope, and navigation. But how about the manipulation, surgical maneuver? How do you do? Using manipulator?
So for this, we intend to get surgical assistance from robots. It will be the surgeon who would be operating with instruments which are long, narrow, catheter-based. These are called catheter-based robotic assistance. Say, for example, a CUSA, which can be introduced at the tip of a very long, small tube. Yes. And the robot will help you to position it without any tremor. So we are not looking at the surgeon sitting somewhere else, but the surgeon can position it with vision, but the robot will help you just position it. The final decision, manipulation would be the surgeon.
Manipulation is done by surgeon, and the robotics assisting the localize the instrument to.
Yes. It will help you to hold a drill without any pressure on your hand.
I see.
You can, on 3D, you can mark out the area to drill, but the drilling will be done by the surgeon.
Okay.
We can put firewalls to make sure the surgeon doesn't go away from any field that is specifically set. The robot can do that. We can have firewalls around so that if there is a carotid, we can put a firewall there so that the drill doesn't go into that region. But the drilling will be done by the surgeon.
Okay, great. Okay, thank you. I got it.
Thank you. Any other questions or comments by the panelists? John, would you like to ask him something?
Cheiran, I think it's a very impressive
yes,
idea.
Please. Yeah.
At the moment, I think that's the best use we can have with the robotics as a good assistant. So that, in a long surgery where we need to operate for 4 to 5 hours, we can take away the fatigue of the assistant. For example, holding an instrument, endoscope, or whatever it is. I think that's the best use what we can put to right now. I think it's a long way to evolve, as you rightly said, to make it into a routine in the neurosurgical armamentarium.
Thank you.
Thank you.
Any questions Any comments? Robotics, would you like to say something?
Come on, Warlick.
I'm not able to hear any one of you because my phone is, the volume is very, very low. I don't know why.
Okay.
Oh.
Hold on. Let me unmute.
Now
let me unmute Warlick. So, okay, Warlick, you're unmuted. Go ahead.
Thank you for your lecture. It's very interesting and very advanced. So it's a reminder we are the future trends of neurosurgery. What is the future of us? So we are doing lots of technologies. So thank you.
Thank you.
I have a question.
Yes, Manuel.
Yes, please.
Hello, Professor Cheiran.
Yes.
Okay, for example, in the future, there is possibility like the robot Minerva, NeuroArm can become like the Da Vinci robot. Can perform the surgery itself, because now you say, for example, the robot you show us is like the assistant. But in the future, if there is something like the robot can make, I don't know, for example, if the robot can make the approach or something like that.
Yes. I mean, very soon, maybe in the next 50 years or so, we can have robots making the approach. But right now, our hands are better than most robots.
Okay, Professor.
So you think, for example, the development of the assisting robots can be performed like I don't know, 5 years, something like that?
Not 5 years. In less than 2 years, this will be ready. In less than 2 years, the robotic assistant for holding drills, holding CUSA, corblator, debrider blades, suction, irrigation, hydrodissection, all these will come.
Professor Iype, I have a question.
Yes, please, Kabulo.
Yes, just in the same way with Manuel. My question was, I wanted just to understand at which point are you now using that after you've positioned your patient? Are you the one opening the skin, you remove your bone flap? At which point now do you use that robot?
We are not using it at all right now. This robot is under development. Only the first prototype is ready. And after the first prototype, we have to do lab work. So we have to get the robotic assistance and do cadaver work first. And after 6 months of cadaver work, we'll have to appraise it as to how good it is for, as Professor Venkatramana said, how it takes off your fatigue, how it will help you for procedures, very fine procedures like drilling, anastomosis, and other procedures. We will list each procedures and see how better we are, how we can push the boundary with these kind of robots. And then only we will start using it in the clinical trials or in patients for maybe for simple surgeries at first, and then going on to more and more complex surgeries. So in the next 2 years, I hope that we can do this.
Thank you so much.
Thank you.
I'd like to make a comment here.
And another question?
Go ahead.
Professor, for example, there is possibility like if using that kind of robot assistant, it gets the neurosurgeon get less skills, lose skills, maybe? Because, for example, if the neurosurgeon always use the neuro navigator, the neurosurgeon lose anatomy skills, landmark lose, because it's like it's easy. I have the neuro navigator, so I go straight. And now I have the robot, and it's more easy for me.
But Manuel, this has already happened, because most of the neurosurgeons right now don't know how to do an aneurysm, because there is coiling. Everybody is using coiling, so most of the neurosurgeons in the West have less than 10 or 15 aneurysms in a year, while in a good week we do that. So the skills are being lost already. But
Okay.
what is better is the question. If the neurosurgeon of the later year may be good at more video games rather than really operating. So this is the need of the hour. If that is what is needed for the hour, you cannot have the neurosurgeon sitting down and having operating skills. So the skills will change. But the whole point is the surgical experience and the results we should improve. And I mean, for example, 10,000 years back, the skills to survive was to hunt down a mammoth. But today, obviously, that skill is not going to help you anywhere. So obviously, the skill sets will change, but the results has to be better. That is what matters finally.
I totally agree with that concept. You know, the residents are already, you're using navigation regularly, cannot mark a flap without navigation plate. Precisely, you know, there are errors that are possible. But having said that, we need to go forward, making much more minimally invasive and much more safe. And to keep these skills, I think we need to have a good virtual reality labs parallelly, where residents have to learn certain basics so that it will not go out of their hand in the rest of the life. And then replicate the same thing with the navigation, so they actually get better and refined.
Yeah, but people are using GPS to go home. So earlier, that never used to happen, but people are now using GPS to go home. So I think these kind of skills are going to come down for sure. There is no doubt about it. I'm already seeing it. But it is for the better that now the modern neurosurgeon would need to play better video games than they need to be better gamers than neurosurgeons.
Professor, I have a question regarding the vision of maybe not of the surgeon itself, but the helper, because I have used the Byton last week for microanastomosis here in Peru. I mean, this practice, because I'm thinking about buying one. But I think the problem is like,
brilliant thing. Byton is really brilliant.
Yeah, but I think, for example, if I have the vision of this cat, can you see the cat?
Yeah.
Okay. If I am here, I can see this, and I'm gonna see only this in the screen. But for my assistant, for example, if he sees from down here, he's not able to see, I mean, properly from this kind of side. He will see like my. So sometimes maybe the learning curve, especially for the assistant, is going to be different, because it's different to have my hands in here for my brain, to have it in here to the other guy. That is one thing that I kind of, I don't know. I mean, I know that sometimes in neurosurgery, surgeries can be performed by just the neurosurgeon because it's really, really narrow spaces. But I think that is a challenge for the development of this kind of procedure, especially if we're going to use like the glasses, maybe some kind of software that can shift the image from the other guy or something like that. I don't know.
Well, with the glasses, whatever image is going to be seen is uniform. There is not going to be any shift. Okay, that is the whole purpose of the glasses, because the screen cannot do that. The glasses is projecting, it has got a small projector which is projecting these images into your retina. So it is going to be the same image for everybody. So the glasses won't have such a problem. But then we are going to look at glasses which are 4K, which is not really there in the market right now. So we are looking at many research projects where they are developing these glasses. It's a huge challenge, but we have to make it. There is no other way.
Yes.
Okay, John, your comment is very
Yeah, I'd like to make a general comment. Thanks a lot. And I just want to remind the panelists and the viewers that Iype is presenting from her smartphone, doing a PowerPoint presentation, because we're really after what's on everyone's mind and what's on the interface. You know, this interface of Zoom and webcasts is excellent for bringing the developments of technology into neurosurgery, exactly what we're doing now. We're bringing robotics to neurosurgery with this platform. And let me just quickly show you an interview I did with John Metheny. He is the patient that is in the DARPA program based at Johns Hopkins. He has an artificial arm built for him because they determined he would be a good patient. And he talks, and I put a link on for the panelists if you want to see the interview we did with him. But he described what he went through. Of course, it takes a lot of money to get this robotic arm built. That's why the government is obviously interested too, because of wartime injuries, etc. But it's interesting, the interview. And it shows the interface that we can have with patients that have had robotics done. And Iype and Dr. Hongo, you can interface with researchers, and you can tell them exactly what you need with, with your operation, what kind of robotic type of adjustments need to be made. And that neurosurgeon can interface with the researcher, with the person that makes the robotic. You know what I mean? You can interface with the person that's developing the thing, and not necessarily a neurosurgeon, but someone that's developing the robotic feature. So, and we welcome Dr. Hongo. Any future developments, just let us know, and we'll put you on the air. Back to you here.
Yeah, that's a good point, John, because that is what we need. If we are working on robotic development, we need to collaborate with engineers, with scientists, surgeons, and we need to present the need of the surgeons to them in their languages. Actually, that is the thing.
Yes.
So it's like a hybrid. It's not just one person, one team. It's like a teamwork. Yeah.
Yes.
Okay, so I think any more questions, comments, anything? Or I think we're done for today. That's all. Thank you, Professor Hongo, for your time. Thank you, Professor Cheiran, for coming up with a smartphone. So that's all for today. Thank you.
Thank you.